Great. Yeah, no, it'll be a good experience. And then you talk. Okay. Yeah, yeah. All right, Chair, I'd like to call the meeting. I'd like to call the meeting to order and ask the Secretary to call the roll, please.
Director Garza is absent. Director Kim? Yes. Director Sorrell is absent. Director Webster Cross? Present. Chair Bott?
Present.
And for the record, those directors also present. Director Harrington?
Present.
You have a quorum.
Thank you. Thank you, directors, for being here. And I'd like to welcome Dr. Kim as an official member of the Quality Patient Safety Committee. So thank you. I appreciate your contribution and look forward to it. So the next regular meeting of the Quality Patient Safety Committee is scheduled for Thursday, September 12th at 11:30 a.m. I'd like to ask now if anyone's registered to provide in-person or virtual oral testimony or submitted written testimony to be included in the record.
We didn't receive any registrations and nor written testimony.
Okay, thank you. I'd like to move to section 2 to approve appointments, reappointments of Stroger Hospital Department Division Chairs. There's one department chair initial appointment, one division chair initial appointment, and 5 division chair reappointments being presented, reviewed by Dr. Rudy Kumapule, Medical Director at Stroger Hospital. Good morning. Good morning.
I'm respectfully requesting approval of the following. All the appointments will be for 2-year terms, August 1, 2024 to August 31st, 2026. The 2 department chairs, I will start with Dr. Victoria Allah Jazion Angelova. So after national search, Dr. Angelova was selected to be the chair of our Department of Pathology. In addition to her clinical and administrative roles, she would also hold what they call the CLEAR license. And CLEAR stands for the Clinical Laboratory Improvement Act, which requires any lab to have a physician bearing responsibility. So she will be holding that license for our labs. Dr. Angelova has extensive clinical research interest and experience, including with the INH, specifically with chronic hepatitis and lymphoma and leukemia trials. She obtained her medical degree from Bulgaria and had her residency and fellowship training in the University of Illinois. She joined us more than 15 years ago as an attending physician, became a division chief, and has served in an interim department chair role, which she did very well since 2023. So we are honored to have her as having been selected to be the department chair. The second request is for Dr. Laurel Clark, who was recruited to serve as the division chair of the Division of Consultation Liaison in Psychiatry. And she would essentially oversee our psychiatry inpatient services, Stroger inpatient wards, observation units, and also trauma critical care areas. She will be over all the providers, physicians, licensed social workers, nurses, and so on. She would also be overseeing our substance abuse program. Dr. Clark earned her medical degree from the University of Illinois and did her residency in psychiatry at Rush. She had been with us for a number of years and then had gone to Missouri, and we are thankful that she's returned to occupy this very important position. We are also seeking reappointments of a number of division chairs. Dr. Erin Fallow for the Division of Vascular Surgery, Dr. Yolanda Maki, the Division of Hospice and Palliative Care, Dr. Ina Mahapatra, Chair of the Division of General Medicine, Dr. Stastis Pulakidas, Chair of the Division of Trauma, and Julie Konchak-Nowinski, Chair of the Division of Substance Abuse and Addiction Medicine. these division chairs have been in these roles for variable periods of time. Thank you. Do we have any questions for me?
Any questions from directors? No. I was just, and I know the team is doing to work on this and think through it, but supporting these individuals as they are in leadership roles and governance is important. So anything we can do to support that. But, I'd like to entertain a motion to approve item 3A. The one proposed Georgia Hospital Department Chair initial appointment, one proposed Georgia Hospital Division Chair initial appointment, and 5 Georgia Hospital Division Chair reappointments. Do you have a motion?
So moved.
Thank you. Second. Thank you. Motion has been made and seconded. Is there any further discussion on the motion? Hearing none, then all in favor say aye.
Aye.
All opposed? Ayes have it. Motion carries. Thank you, Dr. Kumaple. Is that how you pronounce it? Kumaple. Okay, thank you. All right, now I'd like to move to our EMS MEC reports. The Sturgeon and Providence Hospital Med Staff action items presented for approval, and the Sturgeon and Providence Hospital Quality Committee summaries are presented for information. I'd like to ask Dr. Akintoran, President of Sturgeon Hospital Executive Medical Staff, presenting reports and medical staff action items for committee's consideration approval. Good morning.
Good morning. So I'm sorry.
There you come down. There you go.
Okay, so this is the summary of the HQPS committee report. The minutes already with the EMS, and the summary is for QPS information only. Just some quick highlights from the June meeting. The first quarter of 2024 initial review completed on the first day of admission. Initial goal was 90%. That was increased to 95%, and we are now at 98%. For the first quarter, positive outcomes of deniers is 85%, which is over the goal of 80%. Pharmacy, easily being compliance was 100% from January to March 2024. We continue working on duplication of PRN orders for pain medication with 30% in the March of 2024 and 32% in April. Professional experience, communication with nursing went from 61.4 in January to 75.6% in March 2024. Wow. And for the doctors, that also went up to 85.3%. No action items were presented to the EMS committee, and there are none for you today. Thank you.
Thank you.
What do you attribute that change to?
Yeah, I was just
Positive change.
go there.
I'm sorry?
What do you attribute the change to? It's positive.
Because
I
of
assume you did something different.
because of the efforts that were put in by the Dr. Peters is there, by the nursing department, and also OPEX, Dr. Pieko here. So great work done by the team. That's what is. That's why we're seeing this improvement. So
It's always nice to raise the bar, but now we have greater expectations.
So Director Harrington setting greater expectations here. But I would like to really commend and congratulate the team for that progress. That Director Harrington's point of view about sustaining that and continuing to move forward. So thanks for all the work and effort. And are there other particular actions to help sustain these numbers and then continue to move higher?
Well, when we need your help, we'll ask. Okay. Thank you.
Good. Any other questions? There might be. Yeah. Go ahead.
I have a
Director
quick question about case management. you said that you review, on first day of the admission, what sort of case management cases are you reviewing? Maybe it's just because on first day here, I don't understand quite.
This is Dr. Pieko.
So these are for the admitted patients, and care managers do an initial assessment, and it had been the first few days when they would come to intervene, and it's been a concerted effort now to push that into day one, so that there's better planning in terms of discharge barriers and exactly where the patients are anticipated to go, as well, kind of guiding the discussions around length of stay, any discharge needs and barriers. So pushing that forward allows people to kind of have those discussions and plan for what the patient may need over the hospital stay. So this first day is the case manager going in and kind of assessing the patient's needs and kind of the trajectory during the hospital stay.
Do all patients get case management?
Dan, is it 100%, Rudy? Case management assessments, is that 100% of patients get? Inpatient, so observation, no. Okay.
Those that are admitted. Yeah.
Just one more question. What does it mean, positive outcomes of denial?
Yeah, sure.
Thank you.
So our inpatient case managers are an important part of our denials management process. So patients, as we are very much aware, are in either observation status, where they can stay up to 48 hours, or they are so ill, they are expected to be here for more than 48 hours or to midnight. So they are under inpatient status. And however, the payers, if a patient is on inpatient status, can decide that there wasn't a clinical necessity for them to be in an inpatient status, but they should have really rather been in an observation status. And so they would deny the initial submission, and then our physicians and case managers will work together. There may be a peer review talking with the payers and the rest, and then they may reverse the initial decision of the denial, or they may say, you know what, we will give you observation. We will pay for observation. So we've been quite successful either having reversing the denial decisions, or at the very minimum accepting payment for observation status versus an outright full denial of payments.
So it's a positive impact on patient experience and the financials.
Yes.
Did that help?
Yes, thank you.
Are there other questions? We'll continue. It looks like the duplication of the PRN order for pain management is still continue work in progress.
Yeah.
Okay. We have Dr. Paul Allegretti, President Providence.
Yes, okay. I also present the credentials report also.
Yes.
For the directors, you have this in your possession. Those are the initial appointments, reappointments, and other changes regarding the credential and staff status for the month of August. August.
The appointments, reappointments, and changes.
Yes.
So we want to, any questions on that for Stroger? All right, can we hear from Dr. Allegretti, and then we can have a motion for both?
Thank you.
Or do you want to do them separately? Thank you.
Good morning.
Good morning.
Everybody. Good morning. I'm here just to present the MedExec item for Providence Hospital, Cook County. We had a meeting on August 9th, and the credentials, people who were approved for credentialing were presented.
All right, any questions or anything you'd like to lift up, Dr. Allegretti, in terms of appointments?
No, just
Okay.
as submitted.
As submitted. Any questions from the directors? We have initial, we have reappointments and, changes. And there was a resignation as well. Is that anything we need that's listed, for Providence?
No.
Okay. There's recommended, the others are informational, so. All right, I'd like to entertain a motion to approve item 3B, the Sturgeon Hospital and Providence Hospital medical staff appointments, reappointments, and changes. A motion, please.
So moved. Second.
Have a motion, motion has been made and seconded. Any further discussion on the motion? Hearing none, then all in favor say aye.
Aye.
All opposed, say nay. Ayes have it, motion carries. Thank you, Dr. Allegretti. Proposed amendments to the bylaws of the Sturgeon Hospital Cook County Medical Staff. So this is, Dr. Akintoran providing an overview of the proposed, bylaws amendments presented for the committee's consideration and approval. President, Sturgeon Hospital Executive Medical Staff. Thank you.
All right, well, thank you again. So you do have the copies of the bylaws, and you have the red line version, which shows all the amendments. But I'm presenting that to you, and also more specifically the major amendments to the bylaws of Sturgeon Hospital medical staff. Now, I'll refer to where they are on the in the big bylaws, the bylaw folder. So on page 10, licensed independent practitioner. This was defined to comply with the law. So any individual permitted by law and by hospital to provide care, treatment, and services without direction or supervision within the scope of the individual's license and consistent with individually granted clinical privileges. Next, Article 2, purposes, and we have 5 in parentheses on page 15. To develop, adopt, and amend policies, bylaws, rules, and regulations to establish a framework of self-governance of the medical staff and the means of accountability to the board, and in so doing, ensure that all medical staff policies, bylaws, rules, and regulations are in alignment with the hospital policies and rules of the organization and procedure of the Board of Cook County Health. Okay, the B there is board. Okay, I think that's the title.
Dr. Akintoran, on just these elements, I think good for directors here. What was the impetus for the bylaws change?
Well, the bylaws, they are usually amended every 3 years or so that they will be brought up to date, and also to make them consistent with changes in rules and regulations.
And then, so that may be in some of these, and then
You're right. So
others would just normal process of observation of operations and responding to that.
Yes, sir. So the next one is
Before you go, did directors have any questions? Makes sense. Sorry, go ahead.
Okay, so for the major one, if you want me to continue to go through them line by line. The next one basically has to do with members who go on leave of absence, and they do not, when they come back, I mean the time they come back exceeds the time their reappointment. Basically, they do have to go through the process to ensure that they still have those privileges. They can still practice them, in a way that will be safe for our patients. So a member granted a leave of absence from the medical staff pursuant to Section 5 shall not be entitled to reappointment under the following circumstances: if the member's absence exceeded the time granted by the leave of absence, and or if the member's clinical privileges elapsed during the leave of absence. If the member has not treated or participated in the treatment of a hospital or a CCH clinic patient for a period of at least 2 years prior to the notice set forth in Section 2A, initiation of this article. The member shall not be entitled to hearing or an appeal with respect to such denial. 1, if a clinical department chair notifies the MSSD, that's Medical Staff Services Department, that one above applies to a member of his or her department, the MSSD shall not be required to transmit an application for reappointment to the member as set forth in Section 2A, initiation of this article. Number 2, except as set forth in 1 above, if a member who is not entitled to apply for reappointment wishes to be considered for appointment to the medical staff, he or she shall submit an application for initial appointment as provided in Section 1, application for initial appointment of this article. I would like to also mention that this process was guided by our legal department. Okay, so Ms. Patel is there. The next one, the next amendment, major amendment, this one is actually strongly recommended by the Joint Commission Physician Surveyor, and this pertains to members who are on summary suspension of their clinical privileges. Okay. Now, when members are on suspension of clinical privileges, this change here that we're putting in the bylaws is to make sure that the process for review of that suspension is carried out in a timely fashion, and also make sure that the case is disposed of either way before it gets to 30 days, in which case that will have to be reported to the National Practitioner Data Bank. You know, before anybody goes there, we want to make sure that we really want that to go there. Okay, I would say this amendment is more or less required, so we are putting in there. The next one is another one which is really this one has to be in there. It was required for us to be in compliance with Joint Commission standards. And this is in regards to Focused Professional Practice Evaluation, FPPE. So when a department shall be responsible for the development of criteria for focused professional practice evaluation at initial appointment, for newly requested privileges, those two, we do them for every doctor that comes on board or that has new privileges. They have to kind of watch them for the first 6 months or so through the process of focused professional practice evaluation. Now, and then the next one, that's as a part of performance assessment plan. Now, information gathered from the FPPE shall be made available to the department as well as the member, and will be transmitted to Medical Staff Services Department for review by the Credentials Committee, or if applicable, other committees such as peer review committee. To ensure transparency, fairness, objectivity, and measurable criteria for any FPPE trigger, the EMS committee shall maintain oversight of every FPPE from every department. FPPE triggers are subject to approval of the EMS committee. This is a requirement of the Joint Commission. Actually, we had to put this in there because at the previous survey, 3 years ago, we actually received a citation for not having this, it was corrected right away. But now we are putting in the bylaws. This is the first time we are making our bylaws after that survey and the correction of that citation. The last item here, oh, excuse me, this is not the last item actually. The next one has to do with removal of department chair. Department chairs have at-risk status, that's their HR status, head of HR is there, and can be removed by the chief executive officer or the person he or she authorizes to do it. Such removal shall not affect the former chair's medical staff membership, medical privileges, or staff category. Actually, this was in the old bylaws, but we needed to clarify that language there to make sure that the CEO is the one that has the authority to do that, which is in compliance with the law and our HR practices here.
I have a question on this. So on the removal not affecting the medical staff membership or clinical privileges, what if there's an issue with the individual that may impact, their medical staff membership? That's just handled separately.
You're right. That will go through the peer review process. Okay. So just if let's say a chair is removed for the leadership performance, okay, well that's fine. We can do that. But basically you can't start also from being a doctor, from the operating, for doing appendectomy or whatever, which is credential to do.
Yes, this is saying just the removal of, if someone's removed from being a department chair, that if there's a leadership issue, then that'll be handled separately from, or a quality or safety issue or other issue, right? And general counsels could, yeah.
You're right.
So I just don't want someone to be able to come back and say, well, this says that, if there is an issue with the person, that you can't remove them.
That is correct. If you are going to take their practice away from them,
Okay.
it has to go through the due process.
Thank you.
I think there's one more. Okay. This next one, this was actually approved by the board already, an amendment to the bylaws, but now is going to be present or included or attached to the new bylaws that we are reviewing now. So this was approved about 2 years ago already. So I would say this is probably for informational, I believe, at this point in time, because you already did it, okay? So rules and regulations are now in the hands of the executive medical staff. Rules and regulations of the medical staff. That it has to do with things like completion of notes and all those kind of things, that the medical staff, they can do that through the executive medical staff. All the other amendments that you see in your red line version are basically clarifications, correction of tenses and typos in the 2018 version. So if there are any questions, please.
Directors, any questions? All right, thank you for the work on these. I'd like to entertain a motion to approve item 3C, the proposed amendments to the bylaws of the Sturgeon Hospital, Cook County Medical Staff.
So moved. Second.
Motion has been made and seconded. Thank you. Is there any further discussion on the motion? Hearing none, then all in favor say aye.
Aye.
All opposed? Ayes have it, motion carries. Thank you, Dr. Akator.
Yeah, thank you, Dr. Batt and directors, and also to our council. Again, I would just want to
Appreciate General Counsel's support of this, and any other comments you want to make? Yeah.
Do you feel that you received the answer you were looking for?
Yeah, I just wanted to make sure that, right, we were not gonna be in a situation where we can't advance, an action that we want to advance because of the way that it's written.
It's two separate processes. It's the HR process and then the medical staff process. So if for whatever reason a chair is removed, and it is related to patient care, then that would be the patient care issue will be directed to the medical staff in the peer review process.
Yeah, got it. Thank you. We'll go to the minutes for May 20th. twenty twenty-four. Minutes were approved at the May board meeting, so they're being presented for the committee's review and discussion if necessary. Any corrections need to be made in the minutes or any questions that are provided? And I'd like to entertain a motion to accept item 3D, the minutes of the QPS Committee Meeting, May 20th.
So moved.
Motion's been made and seconded. Any further discussion on the motion? All in favor, say aye.
Aye.
All opposed? Ayes have it, motion carries. Thank you. We'll go to the operational excellence items. No actions needed for these items. They're only informational. So I'd like to ask Raji Thomas, Interim Chief Quality Officer, to present the OpEx dashboard. And then we'll go to the update from the OpEx work groups. Good morning. Good morning. How are you?
We'll start with the Stroger OpEx dashboard. For patient experience, the two metrics that we are closely monitoring are the rolling 12-month top-up for communication with nursing domain. As you can see there, for the past several months, we've been performing above our baseline. When you break that down further to look at the monthly performance, after holding steady above the baseline for a few months, we did see a slight dip below our baseline for the past 2 months. The team is here to give further information around how they are planning to, dig further into those observations, those data points, and how they are pivoting with their strategy to address those concerns. In relation to the survey response rate, which is one of the two metrics under patient experience work groups, we did see a drop with the monthly survey response rate as well as the 12-month survey response rate. I know Ling is here to present further on the details around that. I don't want to steal her thunder, but I would say one of our continuing challenges around survey response rate is around the number of undeliverable surveys we continue to see. There are a few other factors. I'm sure Ling would be addressing those in her presentation. Yes.
What does the color coding mean?
Oh, I am very sorry. So red means we are performing below the baseline. Light green means that we are above our baseline. Dark green means that we are at the goal for the year. Purple means we are close to the stretch goal. So we want to see all purple or at least dark green, but sometimes we know that's not the case. So moving on to the clinical outcomes, we had a very strong performance for the past several months. However, as you can see, for CLAPSIs and COTIs, we did see a little dip in June. The teams are really taking this seriously, and they are digging deeper to understand what led to this, the spike that we were not expecting. There is still a lot of analysis being conducted right now. The work groups are performing some root cause analysis to see why this unexpected spike occurred. We will be back to the board next month with more details around what our findings are and what we are planning to do to address the issues we are identifying through this analysis. The monthly VTE is slightly high. However, we are, the teams that are working on these metrics are very confident that the numbers we see is not because of any issues with the clinical aspects of managing these patients. We do understand that we have some opportunities with data abstraction and coding. So that is something, so VT management, VT coding, data abstraction is being built into our overarching work around PSI coding issue. So just want to point that out, that it's not really the clinical aspect, but more of our documentation issue that has led to that increased VTE we see there. Going down further into the readmission data, we are actually doing very well. As you can see, for the rolling 12 months, we've been holding steady above baseline, even at our, target goals for past several months. And moving down, as you see there, for all cause, all payer, all age, we are even touching our stretch goals, for throughout the year multiple times. So that's something the team is really celebrating as a win. Even going down further into the IHA, rolling 12-month, all cause, all payer, readmission, including all other hospitals, we are really holding steady about our baseline. And from what the teams have shared with me, our numbers are pretty impressive comparing to the state averages too. State average is 14.43, and we are at 13.03. So a lot to celebrate there as well. For the throughput team, I know Dr. Pierco is here, eagerly waiting to share the information on why we are seeing some red metrics there. However, as we mentioned to the board in the past, the teams are pivoting on their tactics that they had identified at the beginning of the year. And we are hoping that in the next couple months, we would start seeing a change, a trend towards, light green and dark green that we have for Roger. Moving on to the Providence dashboard for patient experience data. For the domain on community.
Ask a question?
Yes,
Sorry.
please. Sorry.
Before we go on. So, for example, readmission, that's percent, right? So 7.7% means 7.7% of all admitted patients actually readmitted. Is that how you read it?
CMS definition for readmission. I'm sorry. Could you elaborate a little bit on your question?
No, I just want to know what these numbers actually mean. So in the readmissions box, if it says 7.7%, it means 7.7% of all Cook County admitted patients readmitted.
For Stroger and on this dashboard. So yes, it's all inpatient discharges that came back to, and on that second line, it's back to Stroger.
And the bottom line, LOS, let's say 2.6 meaning.
So that's geometric mean length of stay, which is kind of a risk-adjusted target length of stay for how long we expect the patients to stay. That is the variance to what that number is. So if it's 2.5, then that means on average the patients are staying 2.5 days longer than that risk-adjusted target.
Great, thank you.
All right.
Thank you for the question.
Thank you. Providence dashboard for patient experience.
This, we'll come back to survey response rate later, but keep going.
So patient experience data, as you can see there, it's been trending really well above our baseline for several months now. In the recent months, as you also can see from the table there, we've been trending above the stretch goal at Providence for patient experience related to nursing domain. Survey response rate for Providence, we are doing very well. However, we did see a drop in the month of June. So our goals would be around sustaining our, the work that's occurring there and the improvement we've been able to accomplish. For clinical outcomes, so again, patient experience team is here from Providence to present on their tactics as well as their efforts around ensuring sustainability. For clinical outcomes, we did see some concerning trends with sub-1 bundle compliance. So the teams are focusing on improving their efforts around ensuring, nurse leader rounding on those patients, and also improving the response time to the reflex lactate, which continues to be a concern for us at Providence. So they are working on hardwiring that data, hardwiring the expectations for the teams on ensuring bundle compliance. Hand hygiene compliance data, as you can see, is looking really good for Providence, which we are really happy about. This was a new process and practice or reinforced practice that we had introduced at Providence a few months ago. For throughput data, the teams are here to present again. After doing very well for a few months, the left without being seen has gone up a little bit. But the team leaders, diet leaders, will be presenting on what new tactics they are implementing to address the dip that we are seeing there. Moving on to the ACHN dashboard.
Just
Yes,
a
please.
question. With the leaving without being seen, what's the average time in the wait room for the emergency department? Oh, I know. Okay, yeah, because I'm wondering if that's affecting the leaving without.
Well, if you want to respond, could you please use the mic, because the others can't hear.
I apologize. The meeting is live streamed to the public, and so all they hear is a complete silence when you're not in microphone.
Sorry about that. We expect people to be seen by the nurses within 15 minutes. And so we've also, one of our tactics has been to move a physician out there to do a rapid assessment. So, but it can vary by day, given the volume we see.
Because I'm wondering if that's affecting the leaving without being seen, is the time spent in the ER. And then just going back to the patient experience, it just seems like we're up and down, you know, in terms of the performance. That is not a trend line yet?
That is with patient experience for Providence. You see a lot of purple there, which is really good, but you are right. Our goal is
every
to
other month it's red and then purple.
sustainability.
Red and purple. Yeah.
You would, once Lynn presents on that data, you would realize that, you know, for Providence, one of our biggest challenges is that the number of responses, surveys we receive back, significantly varies from month to month, which could then significantly have an impact on, you know, any of these domains. Because, you know, if you get 5 surveys back, one of those surveys has, you know, a wrong, you know, like a low score, then that does seem to affect.
Okay.
And Pat, sorry, so Ling is gonna do a deeper dive on patient experience, but we're also working to kind of hardwire additional tactics, right? There's nurse leader rounding is still kind of coming up, and really, you know, the broader teams have been, educated on standards of behavior, right? So CI care is the acronym that we use. Ling and team have kind of taught that across the organization, so now it's reinforcing, ensuring, and, you know, with the leader rounding, it's really kind of probing into, if we're not using it, why aren't we using it? Really validating, are they aware of it? Do they need, you know, retraining? Is there some other barrier that maybe we're not even aware of, right? So, you know, kind of putting that process confirmation in to ensure that we're, you know, actually doing what we think we're doing.
Yeah, and also the sample numbers that we get is very low. The magic number is 30, and we would get about 15, 14, and so the numbers will always be volatile because it's not at 30 yet. So, and we're working on the response rate so that we can hit at least 25, 30 each month. Yeah.
So again, you're not taking a hit. Does it get reported publicly?
Yeah, these metrics are on because they're specifically on this dashboard because they're publicly reported metrics.
Right.
Right,
So for Provident, we're not quite there yet.
No, not
we're
Provident.
waiting. I think our surgical volume is what's keeping us from triggering star ratings and leapfrog. But the thinking here was, let's get the process up, let's get the system in place for Provident for when we do kind of reach that tipping point and become.
Okay, I think it's 100 cases.
Yeah.
Yes. Thank you.
Thank you.
Thank you.
For ACHN dashboard, we will start with patient experience domain again. So for rolling 12 months, concern of nurses assisting with problems, we've been trending about the baseline for several months now. And Debbie, would you mind moving on to ACHN, please?
Oh, yeah.
And for 12 months, provider explanation of problems and conditions also, you know, it's been trending very well for Providence, ACHN for several months now. Same with courtesy of registration of staff. This is a new metric that ACH and work group had introduced this year. As you can see, for the past several months, we've been doing very well for this particular metric as well. For HEDIS, we continue to do very well about our goal. So the teams are looking into sustaining those behaviors and tactics. That concludes my report.
Great. Looks good results on the ACHN, so good work. Any questions, directors? Okay, thank you, Roger. We'll have update on throughput from Dr. Pierco and Peter Sessi. Thank you. Sturger Hospital throughput.
Good morning, Mr. Chairman. Thank you for giving us the floor to present updates from Operational Excellence Throughput Committee. I would like to start with setting our goals. So for this year, our main focus is on improving our geometric mean length of stay. As Dr. Mikaitis already explained this particular metric, our goal is to reduce it by the end of this year by half a day, and with stretch goal of reducing by 1 day.
Could you say why those goals were picked, that particular number, half a day and a day?
Yeah, so our performance last year was that geometric GMLOS variance was 1.3 days. So in the steering committee opinion, achievable goal was to reduce it by half a day by the end of this year. Aspirational goal is to reduce it by 1 day. So hopefully with our efforts on front and in emergency department, improving our processes on inpatient services and streamlining discharge processes, we will be able to achieve this goal by the end of this year. So what we are looking for, our specific tactics are to modify our medicine service admission model. We will be going live September 1st with a new model of Q4 admission model, where medicine teams will be admitting patients on a specific days with very significant presence in the emergency room, where they can assess patients very early on. They can discharge patients from the emergency room and start providing patient care early on to ensure faster discharge later on. We are focusing on discharge planning on the inpatient side and with number of initiatives that we will discuss on the next slide. And of course, looking at decreasing our operational throughput, turnaround times for bed assignment, patient transportation, and room turnover. Next slide, please.
Good morning, everyone. My name is Peter, and I'll be presenting next slide. So our current goal for the ED was to reduce our length of stay by 1 day for our admitted patients, as Dr. Pierco was stating. So we do have some new tactics that will be going live on September 1st. So on the right-hand side, you'll see those. They're already all in the made. They're already all currently made, and they will all go live on August 31st, September 1st as we go live. So with that, we're going to go ahead and reinstate our admission bolus. So with that reinstation of the admission bolus, like Dr. Pierco stated, patients will be seen in the ED sooner before they even get their admitted bed upstairs. We will also modify our Cerner orders, so we'll be admitting to groups, as well as optimizing our Tiger Connect, as well as optimizing the ED to medicine admission.
Modifying Cerner orders, could you speak a little bit more about that? Is that just the way you're admitting through Cerner, or when you say modify Cerner orders, what specifically does that mean?
Correct. So right now what happens is when we do an admission, when the patient goes to a certain unit, then they get admitted to that service. So now they'll be like medicine firm A blue, medicine firm A green. So basically we'll go ahead and pre-admit them to that unit, that team, and that team will come and see the patients within the emergency department.
Okay, got it. Thank you.
And you're welcome. And for our emergency department, our left without being seen, our goal is to be less than 2%, and our stretch goal is 1.5%. And our ED arrival to departure, we want our patients to be discharged within 220 minutes. And these are patients that are discharged home and not to the floor. Last month, for the month of July, we actually had a great turnout. Our left without being seen was less it was 1.8%. So we are trending in the right direction, so we'll continue to do the tactics that we've been working with. So what we have currently done is kind of relocated some staff members that we had, ancillary staff members in the front area of the emergency department. Our financial counselors have moved from that area, so our ED team has additional areas to see patients and start treatment on early. We're also improving our door to simple tests like urinary analysis, pregnancy tests, x-rays, and respiratory viral panels. So we're doing those all in triage, so patients aren't waiting longer, because these are sometimes tests that need to be done immediately rather than waiting a couple of hours. Also with that, we're having additional meetings with Provident to increase our number of transfers for patients from the emergency department that are currently holding within our ER. And while Provident has open beds, we'll go ahead and do a transfer if the patient approves it and the accepting team from Provident accepts it. So the patient goes directly from our ED to a Provident inpatient bed rather than waiting if we're currently at a high volume of surge. Next slide, please.
So this is a very busy slide, but it just shows how many initiatives are being implemented on the inpatient side to improve patient throughput. We are working on standardizing our interdisciplinary rounds. The new model will go live September 1st, together with the Q4 admission model. So a lot of work, collaboration between physicians, nurses, social workers, case managers, physical therapists, and pharmacists have been done over the past several months. We are diligently working with our nursing team on improving our patient average discharge time. The journey was quite successful over the past 2 years. We have significantly improved our discharge time from around 140 minutes to overall 92 minutes in the whole hospital, with 74 minutes just on the med-surg unit in the month of June. This work has been possible thanks to close collaboration with our ancillary services like transportation, EVS. We have created a discharge facilitator team who follow up early with patients, and we have an escalation process for patients who are reaching the expected discharge time. A lot of education was provided to designated staff, and we are very closely monitoring discharging time. We are working on optimizing our discharge lounge. This is a very important part of discharge process. There is a project of expanding and making it more useful for all of the units to discharge patients to discharge lounge whenever patients are ready. In addition, we are proactively working on assessment and resolution of various discharge barriers. We have created collaborative groups for patients requiring hemodialysis center placement. Members include team members are from nephrology, care coordination team, financial services, and the goal is to really early identify patients who have end-stage renal disease. We are working to decrease the time to completion of 3801 forms for financial services and obtaining immigration Medicaid. So we're also working with vendor patient portal, and our goal for placement is less than 5 days. In addition, we have been working very closely with our palliative and hospice services. The collaboration is important to really early identify patients who have terminal illnesses. Our goal is really to increase discharge disposition of patients with terminal diagnosis to hospice and reduce discharge disposition of patients who expired in the hospital. Next slide, please.
Thank you, Dr. Pirco. Some additional goals we're working with our teams are with our transport team, our EVS team, and as well as our bed control team. For the goals for our current transport time is we want to reduce their patient transport turnaround time to less than 37 minutes. With those, we've put in some tactics for specific transporters to be actually housed in the emergency department and radiology department, so patients are not waiting to go ahead and get their testing done. So we're able to easily deploy transporters to pick up patients from the ED to send them to CT, X-ray, et cetera. Also, we're tracking the efficiency of the jobs per hour to making sure that we're seeing a trend. We recently had noticed something that a lot of people would go on break at the same exact time, so now we're staggering that to see an improvement in actually our turnaround time for the transportation. Also, another thing we are currently working on with our EVS partners is reducing our turnaround time for the rooms from being dirty to clean. Our goal is less than 60 minutes. Currently, in the month of July, we were 65 minutes, which was great because last year we were about in the hundreds. So this is a great within 1 year accomplishment. Discharge cleanings are set from 1 p.m. to 9 p.m. A surge alert is set out if we have patients greater than 15 patients waiting in the ED. And then at that time, the EVS partners of ours go ahead and, God bless you. Thank you. EVS partnership goes ahead and calls people in to have them come in early to prepare for these discharges so we can get the turnaround time and have these patients upstairs and not waiting in the ED. With that, as stated, additional staff during those surge times. Also, our turnaround time for reduce the bed assignment time. So it's less than 15 minutes. So we're kind of keeping track of our furloughed beds and our block beds and our reserve beds. We're keeping very close on patients who are supposed to be direct admits for chemotherapy example. If they don't show up within a certain amount of hours, we contact them to let them know, and if they're not here within a 4 to 5 hour period, we reopen that room, so we're not keeping patients waiting in the ED. As well as for our patients who have to have kidney biopsies, when we're aware of these surgeries and all that, if there's anybody who hasn't showed up within a certain time frame, our team calls them to touch base with them to making sure if they're coming. If not coming, we release those beds so the patients in the ED aren't waiting any longer. And that's all I have. Next slide, please. If there's no question. Okay.
Yeah, so this is the graph showing our monthly variance to geometric mean length of stay expected. We had a significant spike, which was outside of normal variance in February. We are currently trending in the right direction. I strongly expect that introduction of the new admission model will reduce this back to our expected goals. Thank you.
Any questions?
Sounds exciting.
Thank you for the good work.
Thank you.
Thank you very much.
Thank you, everybody.
I invite Dr. Allegretti and Amy O'Malley of Providence Group.
Good morning, everyone. This is Amy O'Malley. Next to me, she's our nurse manager in the Providence ED. So we started our project on February 14th, actually, with an initiative to decrease the LWAS in Providence ED. Two main points of it was to have a provider in triage doing rapid evaluations, which Stroger does as well as the second part is the pull to full, meaning that we fill every bed in the ED from patients in the waiting room as much as possible. Next slide, please. So we are successful in most of that. The rapid evaluations, we kind of downtracked a little bit recently, but actually over the past month, but over the past week, we have increased it with some motivation for our providers. Pull to full is, you know, it's up and down. It's a bit of a struggle. It depends on the nurses who are working, but, you know, Amy and Mr. Moonen are on top of it, following the daily operations in the ED, so we're hoping to keep that going. So we're mostly in the green with this and yellow, a little bit of yellow too. We're still working on that. Next slide, please. And as you can see, we started out really well when we began in February. It was a bit of an adjustment. We did well in March and April, and we struggled a little bit in May, and we have recently as well too. You know, our volume is up, and we're actually down 3 providers, physician assistant providers, which, you know, when we do fill those positions, I think it'll help us tremendously because they're going to be working during the time that we see most of our patients, and their primary job will be to to do the rapid, evaluations. We did interview several people. We put a decision to hire in for 3 of them. Actually, for 5 of them, and we'll take the top 3. And hopefully, we can get that through human resources to get those patients, those, physician assistants in place to help us with our volume. Amy, do you have anything?
Yeah, I would just say that, you know, our census right now in the ED can vary from 50 patients to 100 patients. So adjusting to the volatility of those, the number of patients that come in can vary, as well as the admissions that we send up to 8 West to the ICU. We can have one day, some days we get 15, you know, so we've been working with the teams on 8 West. We've been working with the ancillary departments to make sure that we've got radiology, tasks, laboratory, housekeeping, transport. We have a monthly throughput meeting where everybody reviews their numbers. We do have to continue to do individual coaching. We do not have a permanent charge, a second permanent charge nurse on the day shift. So that does vary. We have posted that position so that I think once we get a second permanent charge nurse, that will help us reinforce that. We're also doing rounding in the ED in the waiting area. So the folks that are waiting, we're trying to utilize all our space as best we can. We had every darn bed open yesterday that we could. And one of the things we did realize is one of our tactics was to put an ER tech out in the waiting area as well as a provider there to do the rapid assessments, but we never created the space. So currently we're looking at a space redesign so that there's a spot where the provider can actually talk to the patient during that rapid assessment and the ER tech can actually do their work. So we've got a number of different things moving forward.
How does Stroger and Providence, because you're both working on the same issues, design may be different, you know, in terms of, but how do you collaborate to find out the best practices?
Well, I know when we kicked this off, we did talk to them to see what their best practices were, and it was the pull to full and then having the provider out there to do the rapid assessment. So those were the key tactics that we worked on, yeah.
And then these presentations actually kind of work their way through the organization. There's a step where there's Operational Excellence Steering Committee, and that's everybody comes together. So these presentations happen with kind of senior leadership, all the teams working on, you know, their various pieces. So there's a conversation that kind of happens naturally there.
Okay.
And that was where we got the idea for the space redesign, because that was something that was on Stroger's.
Yes.
And I was like, wait, we can do that. So, yeah.
It does work when you do have the providers out there and can rapidly assess. Yeah.
Great. Any questions, other questions, directors? Thank you. Thank you.
Thank
you. I'd like to ask Lin-Bang and Dr. Zoccoli and Dr. Witten and James Driscoll. Patient experience for Stroger and Providence. I know we're running behind a little bit here, but.
Good morning.
Good morning.
Lin-Bang, Chief Experience Officer. Dr. Dozie is not here, but we do have Dr. Witten with me. Good morning, everyone.
Good morning.
So first, I want to preface that patient experience takes the village, right?
Yes,
it's
it
a
does.
team effort. I'm very grateful for the support of Dr. Makaitis in understanding the importance of patient experience. And also I'm also grateful for the partnership with Dr. Witten and Dr. Dozie, and especially Ms. Jennifer Rosenrich for pulling all the data and helping us with our slide deck. Okay, so great. Here we have our A3s. Our top 3 focus are the communication with RNs, nurses, our HCAHPS response rate, and then also implementing the OAS caps that was mandated by CMS at the beginning of this year. Next slide. Here are our actions and tactics. I'm not going to read through them, but we'll provide some of the highlights, and then Dr. Witten will give you some more details as to what the tactics are. But since rounding is a correlation of patient satisfaction, it's one of our top goals. And as we evaluate the roundings that have done, we realize that we need to do purposeful roundings. And there are some other tactics like implementing, creating the patient experience playbook, and also commitment to sit. But Dr. Witten could add more of what we're doing.
Yes, thank you for this moment. A few things. Our focus is on compassionate care, and in order to have compassionate care, we're working with our front line to really understand the importance of being on stage at all times. So we're really focused on the leadership rounding. What does that mean? We're rounding on our associates around the clock, really going over what's working well, what's not going well. We have instituted training, which requires CI care. It's important that when our employees go into the room, that the patient feels the love, that we articulate it in a way that they understand, courtesy and respect, listening to them carefully, and making sure that we speak to where they respond. We do get feedback that's coming from the surveys. We'll talk more about that as far as our opportunities, but we do realize this is the elephant in the room. There's a dynamic team that's working on this. It takes a village, and this is the work that we're doing around the clock. Our best practices that's out there, we work and partner with Press Ganey. Our focus right now is really to hardwire the rounding that we're doing and be consistent at that around the clock.
Also exhibiting the CI care. For those who are new, CI care is like AIDIT, except the thing that AIDIT was missing was our first C for connect. So for us, CI care is connect, introduce, communicate, ask, respond, and then exit courteously. Okay. We also have our commit to sit. As you notice, a lot of it is yellow, but good news is that the chairs that we needed for the commit to sit is now back in production. Because of the pandemic, they stopped, and so we're going to start implementing that soon, the minute the chairs arrive.
And we started with the staff training so they can start understanding the concept, how important it is to sit at the bedside, take your time and not rush through. We hear that feedback from the patients, so we're starting on that and rolling that out.
Yeah, and there's evidence-based research showing that just sitting for 1 minute feels like 10 minutes. And so everyone understands that we just need the one chair. Okay. And then next slide, please.
I do have one question, and I like that post-discharge phone calls.
Yeah.
Do you specify certain types of patients based upon their conditions, or that you think could be at risk? And is there a correlation with readmissions, drops in readmissions?
That's a great question. We do go after certain DRGs, diagnoses that we looked at, because it does affect your readmission. We want to make sure that they understand their discharge planning. Of course, we want to stay up front. Our goal is to round on every patient that we possibly can to really meet their needs before they are discharged out of the hospital, to understand that. But we see the impact of that discharge call and how it can help decrease your readmissions if you focus on making sure that patients understand their plan of care. So it's all correlated. We have a solid team, same core team. We're looking at what works well and what we need to do in the future as far as adding a few more people to help, because our goal is to increase those discharge calls, but through another platform that we're working on in the future.
Yeah, so, because as you notice, our goal is 150 calls per month, which is not much, right? But because of, the shortage in staffing, this is what we can do. However, Press Ganey, we're looking at Press Ganey's new service line where they actually do the post-discharge calls. And then the ones that need us to call them back, they'll give us that list. And so that will save us time rather than just making random cold calls and then people are upset because they don't, want to talk to us. Or the fact that they see the number from Cook County and they're not familiar with it and they're afraid to pick up. So Press Ganey will utilize that time rather than us, I'm not going to say wasted time, but being more effective and efficient, yeah? Okay.
Thank you.
Next slide, please. Okay, so here we have our communication with nurses. This is what CMS is actually looking at because it's the rolling 12 months, and they look at the receive date. For those who are new, receive dates are the surveys that are coming in for that month, but they may be, oh, sorry. So you
Or
have
on the
more.
subgroup,
I thought- Yeah, we could skip that one since we already talked about the discharge date. Okay, so I'm sorry. Thank you for catching that. So here, we have a rolling 12 months, and, it's for receive date. This is what CMS is looking at, and, receive dates are surveys that are coming in from people who have been discharged months prior. Right, so we are not looking at the discharge month date. This is, receive dates. And also, when you do the receive dates, you get more surveys coming back. So, let me see, so our communication, with nurses has improved. We're going to wait and see if that will be a trend. But, as you could tell, it was below 70, and our goal is 73, and we're hopeful that, that would.
We are, and those communications that they're looking at has to do with a roll-up of, respect and courtesy. Did they listen? And did we explain things the way the patient understood? Those are our focus and our domains that we're focusing on.
Yes. And also, just an FYI, we have 500 and, how many? Sorry, give me a second. We have about 5,841 total employees that we need to train on for CI Care. Currently, we have trained 4,532, and we still need to train about 1,314 left. And our goal is to finish that by the end of this year. And then we're rolling out a CMS electronic training mandated for the whole system, so that it's reiterated constantly that you need to show courtesy and respect at every interaction with every person that we talk to, including our staff and our colleagues. Okay. And then the next slide is our monthly data. As you can tell, that for April and May, the response rate has increased. And also to sustain where we are right now, we're continuously doing the training and the auditing of nurses on meaningful rounding. Next slide, please. Okay. So all the data refresh up to 6 months historically due to returning surveys. April is subject to change as the surveys are coming in. August, I remember Chair Bott asked about the uptake in August. It turned out that this rate had to do with a lower denominator that was sent out. And this was also during the time frame when we were cleaning out our database and working with business intelligence. And so the lower deliverable volumes and a higher number returned was the result for this particular month. And then we actually have seen an increase in surveys sent to patients since modifying of the data tactic with our BI. Our undeliverable rate has remained the same, which is about 4%, which doesn't sound a lot, but that's roughly about almost 1,000 surveys that are being returned to us. Undeliverable, that got kicked back. Okay, now we can go to the next slide for Providence. So we are mirroring the tactics of Stroger with Providence. Providence has completed the CI Care training. Overall, of agency, we have a high number of agency, but so we provide a condensed version of the CI Care at the orientation. Syntac, actually, the CAP survey was implemented this last January, and we're continuing to monitor our performance with them, but but all of ambulatory care, have had really significant improvement in their patient satisfaction scores. Next slide, please. Thank you. We are trending in the right direction. CCH training, along with using the iRound platform, the measure is consistently above the mean for the last 5 data points. Next slide, please. So this is our quarterly results. Due to the lower return volumes, we have to view the data by quarterly, but I'm hoping that maybe we'll switch it to 6 months so that we could actually have that magic number of 30. And see whether it's truly where we need to be. But our baseline is 74.63, and that's where we're close to right now for this particular quarter. Again, you know, unless it's 30, the sample number is so volatile that we can't really trust the results that we get. Next slide, please. So this data is refreshed up to 6 months back. March came in above goal and stretched at 23.5. 71 surveys got sent and 12 were returned in 1 month, which is pretty significant because at one point we only had like 5 a month. So this has been improving. We need about 25 surveys a quarter to qualify for the publicly reportable star rating at Providence. So right now we're not sharing that number. And then we recently implemented a banner in the patient portal, educating patients to expect the Press-Ganey survey. So this is one of our tactics to help improve the response rate. And also to remind the patient that the survey is coming from Press-Ganey. A lot of times they expect it to come from Cook County, but once they understand that it's Press-Ganey, then they will open the mail and do the survey. Do we have any questions? That's all I have.
I know you mentioned, that a number of surveys were being returned by mail. Have you looked at other ways, such as also being able to send a text to the patient?
Yes.
Email to our QR codes that are in the room so that you can get maybe some ongoing or
So we
feedback?
do the text and the email, but officially the numbers are only being recorded by mail. Yeah.
Okay.
Yeah. But we are doing those other modes as well to get the feedback.
And I know that Press-Ganey is also offering an online soon. The patient can just go online and enter their information. So that'll increase as well.
That's another service line we have to purchase.
And that way you can kind of aggregate that data a little bit better, because it sounds like you might be getting feedback, but you're not able to utilize it in this fashion.
Yeah, thank you. Thank you for your input.
Thank you, Director. That was my comment. Anything else? Any questions, comments?
Okay. Thank you so much.
Thank you.
Now we'll go on to our regulatory accreditation update, used by Marion Marcus, Associate Chief Quality Officer.
Good morning, everyone.
Good morning.
So the August regulatory update includes us completing our triennial survey for both Georgia Hospital and the ambulatory clinics for the primary care medical home survey. And it was a very successful survey. They showed up about 4.5 months early, but we did a really good job. And I want to commend all the staff and the leaders. They did an excellent job. We were 97% compliant with all the standards and elements of performance. However, we did have some findings. We have submitted corrective actions for all those findings to the Joint Commission within the 60 days for that response. And we are also starting to have our departments report out on their compliance measures, and we've created a dashboard to track all of that activity. So we are very excited that they did a good job, and and that we are really interested in keeping, with the, being compliant for regulatory compliance on an ongoing basis. So we plan to launch the Joint Commission Breakfast Briefings. It's a weekly seminar that they host with all the chapters of the standards, and they educate us on what the expectations are. They allow our leaders and staff to ask questions around, clarity of the different asks that they want for us to do. And so that will start on Monday. We know that that's CNC, so it is also going to be virtual. So they have an opportunity to do it virtual. And the staff can get CEUs around that as well. And we will have access to all those webinars for 1 year. So any income, new staff onboarding, we can also offer that to them as well. So we're really excited about that. In addition, since we last met, our infection control department went through a survey with the IDPH about our hospital surveillance data, and they did an excellent job. The surveyors were very complimentary, and they ranked us #1 in Chicago and #3 in the state. So we're really excited about our infection control program and the staff that support all of that. So that is the end of my report. Any questions?
It was a very short report, but I know it's years of preparation, and congratulations, because this is very good. Excellent. Yes.
Thank you.
Echo the comments, Director Mayweather. And I also want to commend Linda and Dr. Witt and their teams for the work on patient experience. That's such an important area that also has impact on all these other metrics we talk about. So, the collective team, just appreciate all your efforts. Thanks for all that you do every day.
Thank you.
Any other questions?
Good job.
Great. The committee will now be going to closed session. Action is not anticipated to be taken. Open session after the closed meeting has adjourned. So we'll proceed to motion to go into closed meeting. And I'd like to entertain a motion to go into closed meeting pursuant to the following exceptions to the Open Meetings Act 5, ILCS 120/2, 1, 11, 12, and 17. Motion.
Moved.
Second.
Motion has been made and seconded. Is there any discussion on the motion? Hearing none, then Madam Secretary, please take the roll call vote on this motion.
Roll call vote on the motion to go into closed session. Aye or nay? Director Garza is absent. Director Kim? Director Sorrell?
Aye.
Director Webster Cross?
Aye.
And Chair Bott?
Aye.
You have 4 yeas and 1 absent.
Ayes have it. The motion carries. We'll now go into closed meeting. So members of the public and those